Evening, and thank you for joining us tonight. We are very excited to offer this event to you this evening. I'm Leanne Sedone. I'm the Chief Nursing Officer and Vice President of Nursing and the Interim President at Suburban Hospital. I've been at Suburban Hospital for over 25 years in multiple roles, and I've seen a lot of great work by my team in my tenure here, but none unlike the rapid, swift, and heroic response during COVID. I wanted to take a moment to acknowledge and thank the community for all of your support over the last 8 months. Your support through supply donations, food, cards, letters really helped pull the staff through this very challenging time. I tell people all the time that we could literally feel the arms of the community wrapped around us, and for that I am so thankful and grateful. This has been a challenging time for our community from a medical, financial, and emotional standpoint. But there has been no other time where I felt so privileged to serve the community and be in healthcare and to be part of the Johns Hopkins system who has led the way through this pandemic. We take our responsibility very seriously as a hospital and a system to help our community get through this trying time. I can assure you we stand ready to serve the community with our exceptional skills, expertise, and compassionate touch. Again, thank you for taking the time to attend this important webinar, for being responsible public stewards, and for all that you do to support Suburban Hospital.
I think this graphic is really great. This is from the CDC, and this is just illustrating what I was talking about, where a lot of different factors converge together to tell us if something is more safe or less safe from a transmission perspective. So we know that masks work for preventing transmission. We know that distance works. We know that outdoors is safer than indoors. And we know that crowded places are not good. So all of these things kind of converge together and can give us a sense of how safe or unsafe a situation is in terms of transmission. Okay, next slide. Great. Okay, so I'm going to talk about therapeutics. Next slide. So Dr. Dobkin alluded to kind of the beginning of things when we really didn't know anything about what worked for COVID-19. And people were trying all different kinds of therapies and using things like hydroxychloroquine that we know now is not effective. At the, a couple of months into the pandemic, the NIH actually convened a panel of expert clinicians, pharmacists, people from other disciplines to put out treatment guidelines. And these guidelines are available online. You can see the website there below. And the important thing to know about these guidelines is it's a living document. So it's updated basically as soon as new information is available, whether it's a study that came out, new data that's available. The panel convenes regularly, reviews things, and determines if guidelines need to be updated. So next slide. So there are many therapeutics for COVID-19 that have been studied. 2 are currently recommended by the NIH treatment guidelines panel, and these are for certain patients, not all patients with COVID-19, and I'll get into that in a minute. And that's remdesivir, the investigational antiviral, and dexamethasone, which is a steroid that's been around for probably many years. There are a lot of other things under investigation, other antivirals, other blood-derived products like convalescent plasma and other blood-derived preparations, monoclonal antibodies, which we've been hearing about in the news a lot recently, drugs that modify the immune response, and also things like blood thinners or anticoagulants. These are all under study for COVID-19. So next slide. So this is just the paper that demonstrated that remdesivir has a beneficial effect in patients with COVID-19. This was a study performed by the ACT-1 study group members. And it really showed us that remdesivir, the patients who received remdesivir recovered more quickly than those on placebo. And that's what it led to it being recommended by the treatment guidelines panel. Next slide. And the efficacy of dexamethasone was shown by the recovery study team, which is a British group, and their study, also published in the New England Journal, demonstrated that dexamethasone actually reduced 28-day mortality, most significantly in patients who were on ventilators, and also on patients who were receiving supplemental oxygen. And there was no benefit for patients who were not needing oxygen or a ventilator. So that gets at my point that not every patient with COVID-19 should get the same treatment. You know, this would never be a good idea for someone who's just, you know, minimal symptoms outpatient situation. So, but for our hospitalized patients, on oxygen and ventilators, this was shown to be beneficial. So next slide. And then this is actually a figure from the treatment guidelines panel, the NIH COVID treatment guidelines panel, and this is available on the website. I'm not gonna obviously go through this whole figure, but I put this in here just to illustrate that there are you know, different categories of disease severity in patients in different situations. And the guidelines panel has different recommendations for different disease severities, and you can see dexamethasone, remdesivir come into play, you know, in different ways when patients are in different states. So you're welcome to go to the guidelines panel website and explore around. They address a whole host of agents that are under investigation, and it's a great website that is updated very frequently. So next slide. Okay, so vaccines. Next slide. So I'm going to talk a little bit about one vaccine that was developed by scientists at the NIH. It's the and then I'll get into a little bit more of the broader vaccine landscape. But I think that the story of this vaccine is, the development is very interesting because it was actually made quicker by what's called prototype pathogen preparedness. And this is, I'll get more into that, but this is a paper by two scientists who at the NIH, Kazmikia Corbett and Barney Graham. And this is how they describe this approach to developing their mRNA vaccine, which is the Moderna vaccine for SARS-CoV-2 in this paper. So next slide. So what the prototype pathogen approach is really building on prior experiences. So I'll explain what that means. Next slide. So there had been, you know, this group of scientists at NIH had been done a lot of previous work on other coronaviruses, MERS, SARS, and as you can see by this phylogenetic tree, which shows how all of these different coronaviruses are genetically related, SARS and MERS are highlighted here. And next slide. SARS-CoV-2, SARS coronavirus 2, which is the causative agent of COVID, is related to these other viruses. So next slide. So since they had been studying these viruses for years prior to this pandemic, they were able to apply strategies and tools for related viruses to inform the vaccine design for SARS-CoV-2. So this includes things like basic virology, so lab techniques that are used to study the virus and study candidate vaccines in the lab, animal models, the ways that different antigens for certain viruses might affect the immune system. So many different things, but really the important thing is experience with related viruses helped make this vaccine be developed more quickly. So next slide. So this is just a slide showing essentially that there are many different vaccines in development. There are many vaccines in preclinical development, meaning not in clinical trials with people, still being studied in the lab and still being studied in animals. And then there are many vaccines in clinical development, meaning in clinical trials with people. And some of the major candidates are falling under a few different platforms. And platform is just the type of vaccine category is one way to think of it. So some vaccines use nucleic acid, and that's vaccines made from mRNA or DNA. And you can see there that Moderna and Pfizer both have vaccines in that category in phase 2-3 clinical trials, so advanced clinical trials. Viral vectors is where a different virus actually delivers an antigen to help your body make an immune response against the virus that causes COVID. And you can see there that there are multiple vaccines in that category: AstraZeneca, Janssen, Merck. And this is not an exhaustive list, you should know. And then there are some vaccines that are made from just a piece of protein. And two in that category are Novavax and GSK, Sanofi. So you can see that this is just a snapshot of the landscape. But the important thing is there are multiple vaccines in late stage clinical trials and taking a few different approaches. So next slide. And the way that these clinical trials can be conducted is actually by people volunteering to be in clinical trials. So one network is the COVID-19 Prevention Network, COVPN. And this is a clinical trials network made by putting 4 other ones together and leveraging that for use in COVID-19. And to see more information about how to volunteer for a clinical trial or about the network, they have a website, so I thought I would just show that. Next slide. And then the other question that comes up is, when vaccines are found to be safe and effective, and I say when because I'm cautiously optimistic, but I guess you don't know for sure, but we can say when. The question on everyone's mind is how is the population going to be vaccinated? Who's going to be offered the vaccine? And how is that process going to work? And I thought I would just say a little bit about, typically the way that's done is the Advisory Committee on Immunization Practices, the ACIP, is an advisory committee to CDC. And that is a committee made up of medical and public health experts. And they develop recommendations about how vaccines, not just COVID vaccines, all vaccines, should be used. And they make their recommendations to the CDC, and the CDC, publishes them and follows them. And that's how we, have recommendations for who should get what vaccine. In this instance, there is another piece of advice, just because this is such an unprecedented situation. The NIH and the CDC actually asked the National Academies of Science, Engineering, and Medicine to also weigh in and to assist them with planning for allocating a COVID-19 vaccine. And I put this slide up here just because they actually put out their final report. And I should mention, this is, their website says that this is one piece of information that will be considered. This is not a decision that any one person is making. This is a lot of different people coming together. But their suggestion is 4 phases, with phase 1 encompassing high-risk healthcare workers and first responders, people with higher risk conditions, and phase 2, other critical workers, teachers, people with maybe moderate risk comorbid conditions. And you can see here phase 3, other young adults and children, and phase 4 would be all other individuals. And I want to emphasize, this is nothing set in stone. This is just the information in their report. But I think that this is probably, you know, you would imagine that if we have a vaccine, probably the highest risk people would be, you know, I would expect would probably get it first. Next slide. But there are, just like many things with COVID, there are a lot of unknowns. So we really can't say anything for certain yet about how a vaccine might roll out. You know, we don't know how many doses are going to be available. We don't know how effective a vaccine will be. We know that any vaccine that's approved will be effective, but there's a difference if something's 90% effective versus 70% effective, and things like that. We don't know if certain vaccines might be better and more safe for different groups of people. We don't know if there might be multiple vaccines available within a short period of time. And you can see there are a lot of other considerations. So yeah, that there are many unknowns affecting vaccine allocation, but that is a snapshot of some of the considerations. So next slide. And one thing I really wanted to emphasize is when we do have a vaccine, it's not going to be an on-off switch that we can all of a sudden stop wearing masks, stop distancing. We're going to still need to keep up these quote unquote low-tech things that prevent COVID transmission following the vaccine rollout. So vaccines are just one component of a prevention strategy. They're not, they're best used in conjunction with other preventative measures. And it's going to take time for the population to be vaccinated, and the degree of protection that the population gets from a vaccine as a whole is going to depend on how efficacious it is and how many people actually get the vaccine. So we're going to keep needing to wear our masks for a little bit of time, and the vaccine is not going to be an off-on switch.
Yeah, so then transport was very critical in transporting our patients throughout the hospital, from the ER as an example, to get CAT scans, chest x-rays early on. The environmental service was key in keeping our hospital clean for our patients and for our staff. Our supply chain was critical in providing PPE that was essential to protect our staff. Facilities was amazing by turning over areas of the hospital to make them into negative pressure floors. Security was critical because they helped, help the family members when they had to deliver stuff to patients in the hospital. Respiratory therapy critical, and when we had to administer high flow or intubations. Radiology in terms of getting x-rays, CAT scans, etc. And in the community, which is who I'm talking to, was critical. You guys really were amazing by delivering a lot of PPE to the hospital. How much food we got, I jokingly say we got a COVID-20 during the time period because of food and just the care and just the love from the community during the peak of the pandemic was unbelievable. So I wanted to recognize all of our hidden heroes. The next slide I wanted to talk about is what I call the Suburban Hospital firsts, which is the following. We were the first hospital within the Hopkins system that actually admitted a COVID-19 patient. We were also the first hospital in the Hopkins system, county, state, to implement cohorting of hospitalized patients, which means not spreading the patients throughout the hospital, but actually placing them on floors so that we sort of could contain the virus, is the way I like to say it, so that it would be located on certain floors so that the other parts of the hospital would not have COVID patients. We were the first hospital in the Hopkins City system, the county, the state to implement STAT testing, a PCR base which turned around in about 45 minutes. We were the first hospital to go ahead and admit a patient to NIH for a COVID clinical trial, which we developed a collaboration through the pandemic and currently. And lastly was partnershiping with Hopkins up at Baltimore. They were integral in transferring patients for higher level of care during the peak times. Hopkins and Sibley were a great partnership that accepted both patients that were COVID or not COVID when we were running out of space in the hospital. So when we think of community, I looked this up and there are two definitions that come to mind. One is a group of people living in the same place or having a particular characteristics in common. And another is feeling a fellowship with other as a result of sharing common attitudes, interests, and goals. So when I think of that, I think of the community, we generally think of those closest to suburban. So as many of you may not know, I actually grew up in Bethesda. My brother and I both grew up in the area. My parents still live about 1.5 miles from the hospital. So I'm actually part of the community as well. But when you think of community, you have to think of outside of the closest neighboring areas to suburban. So the areas that were really hit hard during the pandemic, and when we think of community, is our nursing home patients and our long-term care facility patients, and the Latino population, which is a very underrepresented population that are integral part of our community. And this leads into the last sort of definition of community that I feel like is neighboring with our community hospitals, the other hospitals. These hospitals tend to have most of the Latino population in the county, like Washington Adventist and Holy Cross. We have to work closely with them to partner because a lot of times their hospitals were completely full, and we at Suburban would take these patients to help the community as a whole and the hospital systems within the county as a whole. When you think of the COVID-19, I always say if someone wanted to do their dissertation in public health or their PhD right now, COVID-19 would get an A+ for their dissertation. So we have to think, when we think about COVID-19, we have to be very selfless. And what I mean by that is we have to think of others. So as Eric mentioned and as Andrew mentioned, wearing masks is imperative. When we want to visit family or you have small gatherings on the outside, always, always, always wear your mask. And it's a sense of source control. So you, as a person, are protecting others from any type of viral particles that you may be able to spread. Expansive testing has been critical during this time period and will continue to be imperative as we continue to advance testing throughout the county in particular. Asymptomatic carriers are a huge percentage of patients who are transmitting the disease, hence the importance of wearing masks. A large percentage of patients, as you know, are asymptomatic. Even a larger patient population have mild and moderate disease, so they don't recognize they actually are sick. And if you're not wearing your mask, you are going to spread the disease. You are able to still spread the virus particles, even though you're not symptomatic or hospitalized. So mental health is another area that I have felt and I've seen through the last several months. People become very isolated during this time period. You have to reach out to your family members, your loved ones, your neighbors, who may feel very isolated during this process, and to kind of give them a phone call and check in with them, see if they need anything, if they need any help. And the last thing is influenza season. It's here, it's now. Please make sure you get vaccinated. You can get flu and COVID. It's important to mask to protect ourselves from transmitting any type of viral illness, including influenza or any other parainfluenza, adeno. It's a long laundry list. So it's very important to keep these things in mind. So our future will develop COVID fatigue, but we must help each other. We must be kind to each other. You must take care of yourself and each other. And lastly, I call this the 4-drug treatment. And that is, make sure you wear your masks, socially distance at 6 feet apart, continue to hand hygiene and hand wash. And the last thing is self-monitoring. If you're symptomatic, get tested, isolate yourself, and protect yourself from transmitting the disease to others. Thank you.
So I do have a few questions for our speakers. And if anyone else would like to put a question in the Q&A box, please feel free to do that now. But I'll start to actually, so Sonia, you actually just answered one of the questions, but we'll repeat it just to make sure. Someone had asked the question, can you get flu and COVID-19 at the same time? And I know that you have just recently, just a moment ago, said yes. In fact, you can. Did you have anything else that you wanted to mention about that? Or?
Yeah, so I think it's a great question, and I think now that we're entering flu season, I can't emphasize more the importance of getting vaccinated. We know vaccines are not 100%, so people can still get the flu based on how good the match will be this year. Hence the importance of wearing our masks to protect ourselves. If you even have a small viral burden of any virus, COVID, flu, what have you, you're going to source control and keep it to yourself. Make sure if you are symptomatic, please get tested, whether it's for COVID or flu, but do seek help, get tested, and isolate yourself.
So I'll continue on that theme actually, because someone just put in the Q&A box a question related to that. Two questions related to testing. When is it appropriate to get tested at a testing facility? And is it safe to go there to get tested?
So I'll answer, and I'll defer to my two colleagues who are on the panel as well. It's safe to get tested. I would go find an area that's most convenient to you. We have a drive-through at Suburban Monday through Saturday, if I'm not mistaken. You have to have a script from a physician, set up an appointment, and they will, and I think Eric will chime in, we'll go ahead and do a drive-through swab. So testing is imperative. Don't hesitate to get testing. There's no risk. You must do that for yourself and, once again, for the people that you live with or that are around you. And then the second question was
kind of more related to when, I mean, I think there's probably, we hear a bit about if you're
that's
getting
interesting.
when you should go.
I actually got a call today from someone in the hospital that a family member turned positive at home, but the patient who's here is not symptomatic. And so I think that the thing to remember is that there are phases of COVID. So early on, you may not have a viral load enough to be detected in the PCR within the first couple of days, but there's a 14-day period that we call as a incubation period. The higher yield on the PCR will tend to be when you're symptomatic. But I'll defer to Andrea and Eric if they have any other suggestions.
I would, I agree with what you just said, Sonia. I would just emphasize the point that yes, it is safe to get tested. When I go back to what I said when I was speaking, I feel entirely safe in the hospital and in our drive-by testing area. There's no place I feel more secure, and I can tell you our staff does not want to become infected. So they are absolutely religious about protecting themselves as well as their patients. So if there's one thing I can tell you, it is safe to get tested to come to the hospital. Now, again, having said that, there is nothing in life without risks. So nothing is 100%, but I will tell you right now, I think if I could, I'd sleep. I would have slept in the hospital for the last 8 months and never left if I could.
Thank you so much. Okay, the next question actually is for Dr. Lerner, and this was the first question, one of the first questions that came in. What is the best thinking now about the ability of COVID-19 to mutate in a way that would possibly frustrate the current vaccine program?
Yeah, so SARS-CoV-2, the virus that causes COVID, is like all other viruses in its class, mutates pretty much every time it makes a copy of itself. So what a mutation means is that there's a small change to the genetic sequence of the virus. And that's because it's not perfect at copying itself. It makes little mistakes, and most viruses do this. So the real question is if a mutation happens that's significant, and that would be a mutation in the part of the virus that our immune system recognizes. And so far, we don't have any evidence that that's happened to affect vaccines or treatments for certain. Obviously, this is something that people are keeping an eye on, though. So I know mutation sounds like a scary event, but I think it's important to remember that it's happening all the time. It's just a matter of if it's a significant mutation or not. And we haven't seen that happen yet, but people are watching.
Thank you so much. And this is, I'll give you a follow-up on this one. With the current pause in testing for some of these vaccines, what do you think is the projected time frame, the realistic projected time frame for vaccine?
Yeah, so I think that's the question on everyone's mind. First, I just want to point out that these pauses are actually evidence that clinical trials are working the way they're supposed to, which is when there are independent reviewers that are watching out for monitoring for a reason to stop things and investigate if an adverse event is related to perhaps the vaccine, or if it's just something that happened on its own and is completely unrelated. So yeah, these pauses are definitely evidence that things are working the way they're supposed to in terms of safety. But with that being said, I don't know how long it's going. They're going to have to investigate fully the reason for the pause. So I can't really, I don't want to speculate in terms of time frames. But there are multiple vaccines in advanced clinical trials now, so it's not like all the eggs are in one basket.
Thank you so much. Trying to type in if there's anything.
Can I just double down on what Andrea said? Because I think the question that all of us get, those of us in healthcare, from our families and friends on a daily basis is, hey, is that vaccine, whenever it comes out, going to be safe? And I think what Andrea just pointed out, the fact that they halted several of these trials already, really demonstrates, how close these are being monitored and following the proper procedures to make sure that the vaccine is not being rushed into production for any ulterior motives, if you will.
Yeah, and just one other thing to point out, this is a very common thing that happens in large clinical trials. It's not always that the whole world is paying attention to every little development of a clinical trial. So this is, once you have thousands of people in a clinical trial, this is something that has probably happened in most big clinical trials. It's just that we weren't all attuned to every little development.
Dr. Lerner, someone asked a question here, is if a person knows that they have an allergy to egg-based shots, which is something that I know comes up a bit with the flu vaccine, do you know, will there be any limitations to the vaccines currently in development, and how would a person research that if they wanted to be prepared?
Yeah, so if a vaccine is found to be safe and effective and is available, the CDC would put out guidance for physicians and of who should get it, who shouldn't get it. So really what people should do is talk to their doctor, and they'll be able to tell them which vaccine or which vaccines, when the time comes, would be safe for them.
Okay, thank you so much. And I know you addressed this in your slides, but we'll repeat it here real quickly because someone had a question. Will doctors be among the first to get the vaccine as soon as it's available, when it's offered?
Nothing. I'm not aware of anything that's been finalized. I think a lot of people are thinking about this, but I think a lot people, the certain groups seem to think it makes sense, and I think it seems logical. But we'll have to see what the final recommendations are.
Okay, thank you so much. And one of our attendees also asked for your opinions, where do you feel is the safest place to get a flu vaccine under the current pandemic situation? A doctor's office, a drugstore, the supermarket? Yeah. Dr. Dobkin would like to get his right here at the hospital, which I know is what he did.
I got mine already.
Yeah. Me too. I actually got mine from my daughter's pediatrician. I'd say wherever you can get it, because you don't want to be left vulnerable to the flu. So I'd say, I would say any of those places are safe, and anywhere that the flu vaccine is offered, people, make sure you wear your masks and distance, but I would say the emphasis is wherever you can get it.
So definitely we have the most questions about testing. One of our participants is going to be flying on an airplane in the next couple of weeks and is wondering if there's value to getting tested after she gets off the plane. Does that make some sense? And probably it wouldn't be immediately, right, because of the viral load that you guys just talked about. Dr. Cosby, I know you mentioned that.
Yeah, I mean, I think a lot of us have this thought that, you know, if we get tested before we're around people, that's sort of giving us some reassurance. But I think, as I mentioned, you know, you could, you know, you could definitely be negative today, and in a couple of days while you're around your family, you could actually be positive, but you're not continually testing yourself. Again, mask is clearly most important to protect yourself, you know, from, you know, in terms of protecting others from yourself.
Thank you. And someone else has asked, is there, of all the different types of COVID tests that are out there, is there one that seems more accurate than others?
I have my opinion, but I'll go ahead and let maybe Eric or Andreas speak, sorry.
I usually follow your opinion. So.
Yeah, let's follow your opinion.
All right. So the PCR is definitely the most sensitive, but also it can be positive weeks later, as we have seen in the data. But I think the key thing is, and I'll let Andrea shaking her head, I'll let her also speak to this. I think the question is, you know, and there's been data to show how many days after is the viral cultural bull. And I think that's the key thing. But I'll let Andrea speak to what her thoughts are.
Yeah, no, I agree. You know, tests for COVID kind of fall into three categories. Two of the categories we use to diagnose people who have the active disease, and that's the PCR test, which Dr. Caspo was just referencing with the swab up the nose. Or, you know, there are other methods of collecting it, but that's the most common. And then there's another test called an antigen test that looks for a piece of the virus protein. And as she was saying, those tests tend to be less sensitive, meaning that some people that really have it can actually test negative. But as she was raising, the PCR test sometimes can be almost too sensitive because it can pick up people who were sick and aren't sick anymore, but are just shedding little pieces of the virus and actually might not have any virus live left. So that's why the current guidance from CDC is that we actually stop isolating people after a certain amount of time, depending on how severe their disease was. Not necessarily, maybe certain situations it could be warranted if someone's immunocompromised or it's complicated, but in general, you don't need a negative test. You just wait a certain amount of time after you recover.
Thank you so much. So I know that we've
also like to add one other comment. So I think a lot of people, and I got this yesterday when I was on the COVID unit for a family member, is, you know, should I test my husband later to make sure that he's negative? And so there's no test of cure, I think one point that I'd like to make, because I think there's a perception that there's a test of cure, and it's really, as Dr. Lerner mentioned, in terms of days since positive tests and how in terms of your symptomology.
That's really important. And I know there's probably, we still have many people on the call, even though we've gone over, and we are very grateful for that. We won't take any more time tonight. I see there's still a few more questions, and we will ask our experts those and get back to you. Anyone who still has a question out there, but we want to be respectful of your time and of our panelists' time. So again, thank you all so much for your incredible words of wisdom during this tricky time. And to those who are still on our call, we will be sending out a recording. We also will be sending out a survey, because we do hope to do these webinars every couple of months, and we would love to know what you're most interested in and what you would like us to pursue for our next venture on Zoom. So we thank you very much, everyone, for joining us, and hope that everyone has a great night. Stay safe, wear your mask, wash your hands, stay apart, and take good care. Okay, thank you so much for joining us.